Hello and welcome. My name is Caroline, and today I will be informing you about the science of safe staffing. I want you to close your eyes for just a moment and imagine you are lying in a hospital bed recovering from a complex surgical procedure. You are in pain, you are incredibly vulnerable, and your survival rests entirely on the vigilant observation and clinical judgment of your nurse. Now ask yourself, how many other patients is that single nurse monitoring at this exact moment? Is it two? Is it five? Or is it eight? Well, today I want to inform you about the definitive scientific data behind nurse to patient staffing ratios. In my field of nursing, this is not a routine administrative issue or a staffing inconvenience. It's a matter of life and death. Over the next 10 minutes or so, we will unpack how clinical overload impairs vigilance, look at landmark scientific studies that correlate nursing workloads with mortality, analyze the clinical progression of failure to rescue, and evaluate current public policies trying to fix this issue. Let us begin by analyzing the harsh realities of our current frontline environments. Understaffing on acute care wards has created an environment of workload saturation. We have reached the literal, physical, and cognitive boundaries of clinical surveillance. Furthermore, hospital environments are vastly different from 20 years ago. Because of outpatient treatment options, if you are occupying a physical hospital bed today, you are substantially sicker and more unstable. High acuity patients require continuous and intensive check ins. When a nurse is overburdened, we see a clinical phenomenon called care left undone. Important, but secondary tasks like double checking skin breakdowns or verifying deep vein thrombosis, prophylaxis drop off because the nurse must prioritize immediate crisis. Note the visual on the slide. This is a focused, unhurried bedside assessment. That is the gold standard of care. Under high nurse to patient ratios, this intimate vigilance is completely broken down. This brings up our next central question. Is there hard mathematical evidence that staffing ratios directly cause patient deaths? This statistics represents the single most influential figure in modern nursing health policy. Dr. Linda Eichen conducted a massive study published in the Journal of the American Medical Association, or JAMA, tracking over 230,000 surgical cases. The finding was absolute. For every single additional patient added to a nurse's standard surgical workload, the risk of a patient dying within 30 days of admission increases by exactly 7%. This understaffing also has a direct cost to nursing personnel. Each extra patient increases a clinician's risk of job burnout by 23%. When nurses face moral distress from being unable to provide safe care, they quit, worsening the cycle. How do these deaths occur mechanically? Let us examine the physiological pathway of failure to rescue. Failure to rescue, or FTR, is a clinical quality indicator. It measures whether a patient dies of an expected or treatable complication inside a healthcare facility. Look at the column on the left. Post-operative complications like internal bleeding, silent respiratory failure, or sepsis do not happen instantly. They start as tiny, barely perceptible biological changes. If a nurse is caring for 8 patients, they cannot perform the vigilant observation required to spot these shifts early. By the time they return to the room, the window of rescue has closed. Clinicians are the central surveillance system of the hospital. If you overwork them, you disable the system. Now, let us examine the legal and public policy interventions attempting to solve this crisis. Look at the legislative history. In 1999, California passed AB 394, which officially mandates 1 in 5 medical surgical ratio in 2004. In the decades since, California has seen a dramatic decrease in post-operative deaths compared to states without caps. In 2001 multi-state study confirmed that matching California's ratios in New York and Illinois would have prevented thousands of deaths and saved millions in readmission costs. Excuse me. In conclusion, safe staffing ratios are not a matter of nursing convenience. They are a direct mathematical determinant of patient survival. By advocating for clinical ratios, we protect both the hands that care and the lives that save. Lastly, let's view the peer reviewed sources that build this empirical foundation.